Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss a case of a young female who presented to ER with fever with rash. Okay, can we start?
Yes. 23-year-old female was brought to the ER with complaints of low-grade fever and headache since 3 days, associated with rashes and non-productive cough since 1 day.
Okay.
Initial 10-second assessment, patient was conscious and oriented and obey commands. Primary survey, airway, patient with no pooling of secretion or abnormal airway sounds. She was able to talk normal and able to complete full sentence. C-spine appear normal. Breathing. On auscultation, chest clear with bilateral equal air entry, symmetrical and adequate chest movement. She had respiratory rate of 20 per minute and oxygen saturation of 98% in room air. Circulation, good peripheral pulses, pulse rate of 90 per minute and BP is 100/70 millimeter of mercury. Disability, GCS E4 V5 M6 15/15, pupil 2.5 millimeter bilaterally reactive. Exposure, temperature 100.3 Fahrenheit, adjacent to primary survey.
Okay, so in the primary survey, first we will be checking the airway, breathing, circulation, disability and exposure. So this is a young female who came with fever. So if a patient, young female is coming or whatever patient coming with fever, in the primary survey, what will be the features telling that this patient might not be stable? This patient is stable. What are the other things we will have to look mainly into in the primary survey? Ibn?
The vitals basically.
Vitals.
Hypotension.
So if there is hypotension that means patient might be unstable. Okay, then other than hypotension, in the circulation hypertension, then?
No GCS.
Low GCS, altered mental status, fever with altered mental status, that is also considered as one of the critical stage. Okay, then?
And peripheral pulses not being palpable.
Then
other than that, you can have breathlessness, severe wheeze.
Tachypnea, severe breathlessness, these things. Okay. Then if those things are coming as positive, then we will have to intervene as early as possible. So if airway is not patent, or if the patient is tachypnic, if the patient is having hypotension, or if the patient is having altered mental status, then we will have to intervene immediately. Okay. Adjuncts?
Adjuncts, venous blood gas pH 7.40, PCO2 48.7 and PO2 is 23.2 and SO2 25.2, HCO3 29.6 and lactation 1.6. ECG, normal sinus rhythm at 90 beats per minute with no significant SGRT changes. Secondary survey.
So in this patient, in the primary survey, only abnormality which we can see is a temperature of 100. So taking a venous blood gas and ECG is unnecessary at this point of time because she is only having fever complaint. So that is not required. What you can do here is you can place an IV cannula, take whatever blood samples required, and you can give either an injection paracetamol or you can give a oral paracetamol. Both are equally effective. Okay.
Secondary survey, 23-year-old female came to the emergency room with history of low-grade fever with myalgia, chills and headache since 3 days, associated with rash and cough since 1 day. Cough is non-productive and increases in night. No history of hemoptysis, breathlessness, chest pain, projectile vomiting, dysuria, abdominal pain, palpitation and blurring of vision, seizure and photophobia. Allergic history, no history of allergic history, past history and surgical history, history of hyperthyroidism, not on medication, stopped medication 2 years back, no history of hypertension, diabetic mellitus, bronchial asthma, TB, and there is no significant past history relevant for her present complaints. Took antithyroid medication 2 years back.
Okay.
General exam.
Can you tell some differential diagnosis?
Scrub typhus.
Okay, scrub typhus, fever with rash. Okay.
Leptospira.
Okay. Some common fevers which you see in South India. Dengue fever.
Hand, foot, mouth disease.
Okay. Okay. So she is having a history of fever, cough, and rashes are also. So fever with cough, some differential diagnosis.
Pneumonia.
Yeah. Okay. It can extend from upper respiratory to lower respiratory. So upper respiratory, it can be simple allergic rhinitis can be there, or infectious rhinitis, or any upper respiratory infection. Sometimes it might be associated with some tonsillitis something, and a lower respiratory infection, pneumonia or atypical pneumonia can be there. Okay. Okay. So if you are taking a history for fever, what all things, what are the various parts in the body there can be infection? Young female, starting from head to down, in the brain, head.
Meningitis.
Meningitis. Meningitis can be there, encephalitis can be there, then some brain abscess, then
tuberculosis.
Okay. We already discussed about the upper airway and the lungs. Then abdomen.
Appendicitis, UTI.
Surgical causes like appendicitis, cholecystitis, sometimes pancreatitis, everything can cause abdominal fever. Then urinary tract infection. Then
cellulitis.
Cellulitis coming. So in the abdomen, if it is a male, then we will have to suspect in terms of any prostatitis or any prostatic abscess, something like that also we will have to suspect. And in females, we will have to suspect in terms of pelvic inflammatory disease or tubo-ovarian abscess. Okay. Then coming to skin and soft tissue, there can be cellulitis. Then
Pancreatitis.
Can be there. And in the bone,
Osteomyelitis.
osteomyelitis can also be there. Okay. So this patient is not having any other illness. So is there any precipitating factor or something, if whatever patient it is, what can increase the risk of infection in a patient?
Comorbidities.
Comorbidities, immunocompromised patients. Then like if patient is on chronic on catheters, like for urinary catheter, Ryle's tube, or if the patient is taking some chemo medications and all, they might be having some chemo port will be there, ports might be there, or if the patient is on chronic dialysis and all, they might be having dialysis catheters. So these are sources of infection. So we need to when we are asking history and when we are examining, we need to look into that, and we need to make sure that that does not get infected. Okay. Then other than this thing, recent travel history or recent hospitalization history, these also should be asked. Okay.
General examination. Patient was conscious and oriented, well built and well nourished. No history of no pallor, no icterus, no clubbing, no sinuses and lymphadenopathy, no edema. On inspection, the patient had purpuric rash all over the body. Vitals: pulse rate 90 per minute and BP is 100 by 70 millimeter mercury.
Did the patient notice this rashes in the body?
Yes.
Okay. So did he tell how did it start, where did it start and all?
All over faces.
Started from
face.
Was there any oral lesion or only on the surface, body surface?
Body surface.
Only on the body surface. Okay. How will be the rashes of measles be like?
Mucosal involved.
First it will be starting as a complete spot in the third or fourth day. Then it will be starting as a retroauricular rashes will be starting, and it will be spreading to the body. Whereas in case of chickenpox, where will it start? It will start from trunk and it will be spreading. So you told that these are purpuric rash. So what is difference between purpura and petechiae? A petechiae will be spot like spots. So it will be like somewhat less than 5 millimeter or that size. Purpura can extend up to 5 millimeter to almost 1 centimeter. That much size will be there for purpura. And what is ecchymosis? More than 1 centimeter, I mean, enlarged area that is involving more surface area, that is ecchymosis. So this guy is having, this patient is having purpuras. Okay.
On systemic examination, respiratory system, bilateral normal vesicular birth sound heard, cardiovascular system, S1, S2 heard, no murmur, no added sound. Gastrointestinal system, per abdomen soft, not tender, no palpable mass. Central nervous system, no focal neurological defect, no signs of meningeal irritation. Lab investigation, hemoglobin was 12.6 and platelet 2,11,000. TC was 4.32, DC 63.1 and lymphocyte is 23.9, eosinophil 0.67, total bilirubin 0.22 and direct bilirubin is 0.7. SGOT 23.5, SGPT 20.1.
Okay, in a patient with fever with rash, we have already observed some purpuric rashes also. So, which all are the main lab investigations you will be looking into? Platelet. That is normal in this patient. Then, if platelet is normal,
TC.
Total counts can be checked. Then, other than platelet, coagulation factors, which are INR, APTT. These things should be checked, and if at all those values are varying, then we will have to check into what that is. Okay, so what was APTT, INR? Within normal limits. Okay. So this patient, we have, since you told that on examination we seen some rashes. Okay. What along with, after finding this rash, what else should we ask in the history? Rashes might be some small bleedings under the skin. So what we need to ask for? Systemic bleeding manifestations. What all things should be asked?
Any bleeding? Including cough.
Patient is having cough, so bleeding while coughing out. Then
while passing motions.
Stools or while passing urine, whether there is any hematuria or blood in stools. Then
vomiting. Okay.
Then we need to ask for gum bleeding also while brushing teeth, whether patient notice some bleeding. Okay.
Chest X-ray, normal lung parenchyma, USG abdomen and pelvic, no sonological abnormalities detected. Dengue PCR, dengue virus RNA not detected. Lepto PCR, leptospira DNA not detected. Probable diagnosis, short febrile illness probable.
So when will if you are suspecting dengue, when should we send dengue test?
Third day.
Dengue NS1 will be positive within first 1 to 3 days. Then after that we will be
IgM and IgG.
IgM will become positive only after 5 or 7 days. Okay, IgM will take some time to become positive, and IgG will indicate that it is a chronic infection or past history of dengue is there. Okay, so IgG is not. It doesn't correlate with an acute infection. So NS1 and IgM only will correlate with acute infection. And leptospirosis, when should we evaluate for lepto?
1 week.
After 1 week. So initially, if the patient is coming with suspected lepto-like symptoms, you can do urine test. In urine, we might be able to detect the leptospira organism in urine. But what we are sending to the lab is the IgM lepto. So that is actually antibody against lepto. That will come only after 7 days. Okay. Why was USG done for this patient?
Any organomegaly.
Organomegaly. Okay.
Diagnosis, short febrile illness, probably viral fever. To rule out other causes, short febrile illness, dengue, leptospirosis, malaria, scrub typhus. And treatment, IV fluids and IV
mainly supportive medicines. supportive medicine, we are mainly suspecting it as a viral fever. So antibiotics we will be initiating only to prevent secondary bacterial infection and IV fluids. Okay. What else was done? Okay. Can you tell some non-infectious causes for fever? Other than infectious, we discuss about the infectious, non-infectious causes. Malignancy. Then
any inflammatory
conditions or any autoimmune diseases. Then some common scenarios which we see in here. Neuroleptic malignant syndrome. That is actually hyperthermia, not like fever. What is difference between fever and hyperthermia?
body temperature increases.
So if we are telling based on the degree Fahrenheit and also usually normal temperature is ranging from 96 to almost 100, that is considered as normal. Any temperature more than 100.9 is considered as fever, and if the temperature goes high more than 41 degrees Celsius or more than 104, that is considered as hyperthermia. Okay. Any other causes?
Thyroidism.
So this patient had a history of hyperthyroidism. So in case of hyperthyroidism and thyrotoxicosis, there can be fever. Okay, then Pontine hemorrhage can have fever can be there. Then your pulmonary embolism, acute MI, congestive heart failure can have, adrenal insufficiency can have, then seizures. Anything that is involving excessive muscle activity will have fever. Okay. Then anything else? Okay. Thank you.